Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning all. Professor Adiba Kamaruzaman, Dean of Health Medicine, University of Malaya, and also will act as a moderator to this event. And Professor Dr. Ahmad Hatim bin Sulaiman, Head of Department of and Professor of Psychiatry at Department of Psychological Medicine, Faculty of Medicine, University of Malaya. He is also a consultant psychiatrist at the University of Malaya Medical Center. Dr. Mariana Cordero Diaz, Wellbeing and Professionalism Program Coordinator for the Medical Residents and Fellow at the Tecnológico de Monterrey, Mexico. And Dr. Hervita Diatri, psychiatrist consultant, Health of the Community Psychiatry Divisions, Department of Psychiatry, Faculty of Medicine in Indonesia, and Head of Community Psychiatry, Faculty of Medicine, and also Head of the Community Psychiatry Section in the Indonesian Psychiatry Association. And also we have Dr. Jennifer Russell, Director of Clinical Training for the Department of Psychology and Clinical Coordinator of the Anxiety Disorder Program. As the Regional Ambassador at the Associations of Academic Health Center International, AAHCI, Southeast Asia, and Dean Faculty of Medicine, University of Indonesia, I warmly welcome all of you. It is a great day as we have had the opportunity to gather in our second AAHCI Southeast Asia webinar today, bringing the topic of mental health of healthcare workers during COVID-19. The reason why we choose this topic is because that as healthcare workers involved in the response to the COVID-19 pandemic since the beginning of outbreak, we sometimes ignore the mental health issue that our healthcare workers may undergo on the front line. We must remember that our healthcare workers are not resistant from this issue. They are often required to work in highly challenging conditions and may therefore be at increased risk of experiencing mental health problems. They may also face the physiological consequences of their crisis management work, such as inadequate support, the feeling of burnout, inadequate personal protective equipments. Learning from studies out of past outbreaks, healthcare workers have known to be 2 until 3 times more likely to develop post-traumatic symptoms during quarantine. I think the speakers will talk about this in this webinar. Our health worker also located in the high-risk area and had any friends or relatives that contracted the disease itself. On this webinar, we will hear the valuable experience from 4 panelists from Malaysia, Indonesia, Canada, and also Mexico. And we can discuss the challenges and the lesson learned from our AAHCI members in Southeast Asia regions, Mexico and Canada, as I mentioned. Before I take too much time, on behalf of Association Academic Health Center International Southeast Asia Regional Office, I would like to express my highest appreciation again for moderator and also all panelists. And it is such an honor for us for having you all today. Finally, thank you for all participants for joining today's webinar. This webinar hopefully yields profound awakening regarding this issue, and may all of us are able to stand together during this unprecedented pandemic. Thank you, and thank you for your attention. And please, Professor Adiba, floor is yours. Please, Professor Adiba.
Good morning, Assalamualaikum, and thank you very much, Dean Ari. I would like to congratulate and thank the Association of Academic Health Center, the regional office, for this initiative. I think it's an extremely timely and important topic to be discussing as we live through the COVID-19 pandemic. And congratulations for assembling a very illustrious group of panelists from around the world. And I thank you for inviting me to moderate this session. As you know, the COVID-19 pandemic has presented a very unique extreme risk for us healthcare workers, particularly those working in the front lines. I think not since the HIV epidemic has a disease so closely, present risk to healthcare workers who work with patients that generated so much fear, and rightly so, I guess. The numbers of healthcare workers who've been infected is still, there's kind of reports coming out, but it is still unclear exactly the level of infection that has affected healthcare workers globally. But according to a US report, in the US alone, 120,000 doctors, nurses, and other frontline healthcare workers have been infected by the end of July. And an Amnesty International report states that there has been approximately 3,000 deaths of healthcare workers due to COVID globally. So it is not then a surprise that mental health to healthcare workers has been an issue. Since the report of Dr. Li Wenliang, the so-called whistleblower from China, who passed away in February, the level of fear, stress, and anxiety, I think, has been quite high all around the world. And this has been made more difficult, especially in the early days of the pandemic, because of the, I guess, the speed at which the epidemic was unfolding, and also the lack of knowledge, just from sheer, because this was a new disease that we were dealing with. So the uncertainties around mode of transmission, particularly, is it airborne, is it droplet, which continues to be a bone of contention, also added to the anxiety. And on top of that, you have the misinformation, the rapid sharing of half-truths via social media, then created an atmosphere of uncertainties and fear. And as Dean Ari mentioned, we also had in many places shortages of personal protective equipment that added that gave another layer of concern and anxiety. And finally, in addition to the risk to self, there's also risk to family members, particularly those who are living with adult parents and young children, that created another layer of anxiety and fear for our healthcare workers. So it's no surprise that all of these factors can lead to stress, anxiety, and mental health. And so today we have a sterling list of panelists to discuss these issues, and we'll start off with my own colleague from University Malaya, Professor Ahmad Hatim Sulaiman, who is a consultant psychiatrist as well as head of department in the Department of Psychological Medicine here at the Faculty of Medicine, University Malaya in Kuala Lumpur. So over to you, Hatim.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. Thank you, Prof. Adiba, for the kind introduction, and thank you, Dean Ari, for giving me the opportunity to speak today. It's a great pleasure and honor to share this same virtual podium with all the distinguished speakers. And last but not least, thank you to all the participants who have logged in with us at this webinar today. So I will just share my screen first. Okay. So the occurrence of the current pandemic has led to increased psychological distress and poorer mental health outcome among both healthcare professionals and the lay public. And so basically, psychological first aid, which I'll be discussing my talk initially, is one of the measures recommended by the World Health Organization to help to reduce psychological distress during an infectious pandemic. So in line with the WHO recommendation in pandemic situation, we decided to develop a remote psychological first aid module for our frontliners. So I have both Dean Ari and Dean Adiba have mentioned that healthcare workers, especially the frontliners, were associated with higher risk of developing depression, anxiety, and distress. And there are many factors that contributed to all these negative emotions. And this includes shortage of protective personal equipment, and due to lack of manpower, there'll be probably long working hours of the healthcare workers, fear of getting the infection themselves and later transmitting to their family is one of the main worries that healthcare workers are having, especially the frontliners, and witnessing colleagues who become critically ill, and last but not least, limited access to mental health services are some of the issues faced by these healthcare workers. And psychological distress and physical exhaustion compounded by physical exhaustion can challenge the healthcare workers' immune system and make them more susceptible to get this COVID-19 infection. So in view of its deleterious mental health outcome, so it is imperative to implement effective psychological interventions to improve the situation. So I come from the University Malaya Medical Center, saying like Prof. Adiba. So it's a teaching hospital located in Kuala Lumpur, and was one of the 60 hospitals designated to manage COVID-19 cases in Malaysia. So our hospital has a total of 1,600 beds with 150 beds specifically allocated to manage COVID-19 patients across 8 wards and including 22 intensive care units or ICU beds. So we are one of the biggest hospitals in Malaysia. So the hospital employs more than 5,800 healthcare workers, of which 1,987 staff were assigned specifically to care for COVID-19 cases. And under the leadership of Dean Adiba, UMMC have formed the COVID-19 task force early on, as early as February this year. And the first case in Malaysia, COVID-19 in Malaysia, I think was first reported in late January. And in UMMC itself, we formed the task force as early as February. And the task force acknowledged the psychological impact of COVID-19 outbreak on the healthcare workers. Therefore, the psychological component or psychological issues of the healthcare workers were given priority by the hospital or the faculty management from the beginning itself. So what is PFA? So PFA is a method of helping people in distress so they can feel calm and supported. So the basis of psychological first aid or PFA is caring about the person in distress and showing empathy. So it involves paying attention to reactions, active listening, and if needed, giving practical assistance. So can help to normalize worries and other negative emotions. So it also promotes healthy coping and provides feelings of safety, calm, and hope. So in keeping with the need to limit the face-to-face consultation and to reduce risk of transmission of COVID-19, and also to have social distancing, so a remote method of PFA was devised. So the initial step was to assemble a core team and to develop the protocol. So that's the stage one. So I'm very lucky to have a few experts at my department, especially I should name them Dr. Benedict Francis and Dr. Zuraida Ahmad Sabki as the core team member who really helped to develop the protocol. And in the second stage, where we need to do training and service promotion. And after we have done the training and promotion, we started stage 3, which is implementing of the remote PFA and the psychological assessment. And later at stage 4, we measure the outcome of improvement of healthcare workers' psychological functioning, and if needed, to provide access to either intensive intervention to those who really need further intervention. And at stage 5, which is still ongoing, where we evaluate and review the effectiveness of the PFA protocol, just in case for second wave or third wave of infection in Malaysia. So basically, this is the workflow of the remote PFA in our center. So basically, we have a very good public health department and occupational safety health environment, where they do what we call contact tracing for all the healthcare workers, all these 1,900 healthcare workers. So they do daily contact tracing, risk assessment, and surveillance. So they'll be assessed by the public health department and occupational safety health and environment. So they will refer to what we call the central data collection unit, which is managed by our psychologists and counselors. And these psychologists and counselors get the consent from this patient who are referred, whether they agree to receive this PFA. And they will also collect some mental health data to help us to manage the patient. And once the patient gives the consent, or once the healthcare workers, sorry, not the patient, the healthcare workers give consent, the remote psychological first aid will be administered. And if required, we will do a follow-up of the patient for further assessment. So basically, this is the core actions that is involved in this PFA. So first is contact and engagement, where all healthcare workers who consented to the remote PFA intervention are attended by the providers, because the PFA providers or psychosocial support team via WhatsApp applications, and will be we make the contact within 24 hours of referral. So the PFA is offered once therapeutic alliance is formed, but if help is declined by the healthcare workers, we respect the wish and explain that help is always available in the future in case they change their mind. So healthcare workers receive the immediate emotional support from the providers, and hopefully able to self-regulate his own or her own emotion through some of the techniques that will be taught by the providers, such as breathing technique, relaxation technique, mindfulness, and hypnotherapy, and so on. And the immediate needs and concerns of the healthcare workers are also identified, and the remote PFA is applied accordingly. And if there are severe psychological and social needs, they'll be referred for relevant experts, and for continuous support from colleagues and employers without being stigmatized or discriminated. So based on our data, we found that more than 36% of our healthcare workers suffers from anxiety symptoms, and about 29.5% of our healthcare workers have depressive symptoms. And 16% of them has moderate anxiety and 3.5% have severe anxiety, whereas 8% has moderate depression and 1.5% of our healthcare workers have severe depression, which require further treatment and follow-up. So these are some of the issues faced by the healthcare workers frontliners. At least in the early stage, they have a lot of negative emotions. There are a lot of fear, uncertainty, and anxiety. There's a lot of fatigue and exhaustion, especially those who need to wear the PPE under the uncomfortable condition. There's also some of them presented with sadness, disappointment, and loneliness. However, there are a few good coping strategies that help them to cope better. One of the most important things is to provide adequate safety precautions where the organization, UMMC, have successfully given them adequate PPE for all levels of staff. So this really helps to reduce the anxiety of most of the healthcare workers. There's also good cognitive adjustment and nature defense mechanism used consciously or subconsciously by the healthcare workers. Example, altruism, where they say that, oh, it's good that they can contribute to the country, to the community by sacrificing themselves to help the country. And another important coping strategy is to have a good support system from all levels, from the hospital, from the family, from the colleagues, and also from the general public. I'm very happy to say that the Malaysian general publics are very supportive. There's a lot of donation pouring in during this pandemic, and a lot of support for the healthcare workers. As the regards of perspective of the remote PFA, at least in the initial stage, there's a lack of awareness regarding the service. Few of the healthcare workers are not aware, but we managed to overcome that by having a lot of promotions by the information technology. There's also misperceptions regarding the PFA. Many of the healthcare workers thought that PFA is only for the severely emotional healthcare workers with severe emotional problems or with psychiatric symptoms. So there are a lot of stigma and fear of confidentiality issues, and this, I think, one of the major hurdles for us to give the PFA service to healthcare workers. As challenges faced by the providers, so having a remote consultation have a lot of challenges. There's no face-to-face contact with clients. We as psychiatrists, healthcare workers are used to have face-to-face contact. So having a WhatsApp or Telegram or Zoom session is probably not our usual norm in the past, but now it becomes a new norm. There's also a lot of clients' reluctancy. I mentioned earlier about the stigma associated with seeing a psychiatrist or healthcare workers, and mainly due to confidentiality concern. So in terms of administrative difficulty, so at least in the early phase, there's lack of PFA guideline for ongoing pandemic. Everybody is not sure what is going on, how to proceed further, but that is slowly ironed out as the pandemic progresses. There's also a lot of difference in opinion among providers because our team consists of psychiatrists, psychologists, counselors, even volunteers from other departments. So initially, we had to iron out a lot of differences in opinion. And also, there's communication barriers among the providers themselves because we have to practice social distancing. We ourselves cannot have a face-to-face meeting, so we have to do all this via Zoom meeting or Google Meet and so on. And we have to do some modification of the PFA services. So we have to have some follow-up interventions, just not once, but we have few interventions if required by the healthcare workers. So we organize a lot of online group activities which are well accepted by the healthcare workers. We do some hypnotherapy, relaxation methods, and crisis intervention, and we involve multidisciplinary team involvement to have more successful outcome. So as my last slide and summary, a remote PFP is an important tool in the armamentarium of mental health intervention in this current pandemic and based on our experience. So the relative short training required coupled with its broad applicability makes it a unique and effective option in pandemic situation. And one of the notable findings was that frontline healthcare workers were still apprehensive to receive psychological interventions mainly due to stigma associated with mental illness. I think with that, I thank you for your attention and pass back to Prof. Adiba. Thank you.
Thank you very much, Hatim, for sharing the program that we had here at the University Malaya Medical Center. I'm sure there'll be lots of questions for you later on. The next speaker will be Dr. Mariana Cordero Diaz, who will also share the mental health program for healthcare workers at in her place in Mexico. Dr. Diaz is the Wellbeing and Professionalism Program Coordinator for medical residents and fellows at the Tecnológico de Monterrey, Mexico, and her activities and research focus on ethics, professionalism, the learning environment, and the well-being of medical students, residents, and physicians. So Dr. Diaz, looking forward to hearing about your program in Monterrey. Thank you.
Thank you very much. And everyone, hello, greetings from Mexico. My name is Mariana Cordero Diaz from Monterrey Tech. I am really thankful for the invitation to join this webinar with such a relevant topic of discussion. I will address the topic focusing on the mental health of medical residents and medical students. I will share with you some reference and ideas regarding the following three main points, starting with issues related to mental health of medical residents and medical students. The COVID-19 pandemic has already made an impact in medical education. On one hand, the hidden curriculum of this crisis has challenged medical residents not only in the issues related to patient care and the affirmation of self-worth, especially when they are seen as heroes, but also in being aware of our own vulnerability. On the other hand, the middle and long-term consequences that the pandemic will have to medical residency and MD programs are still unforeseeable. As physicians, we know that we need to continue to take care of patients. But what about our care? Is our mental health in a particular risk, or are we only in a moment in time when we are willing to talk about it? The impact of mental health on medical students' professionalism and well-being has been assessed and well documented at least during the past 2 decades. For example, this multicentric study published in Academic Medicine showed medical students' mental health correlation with professionalism, burnt out, suicidal ideation, and thoughts of dropping medical school. Poor mental health was associated with suicidal ideation and thoughts of dropping out of leaving medical school, regardless of the level of burnout. The prevalence of self-reported altruistic professional beliefs decreased in a stepwise fashion as mental health worsened, with a difference in prevalence reaching a statistical significance more often among the students with burnt out. On the other hand, the impact in medical residents' well-being and mental health has been unprecedentedly documented during the past 3 decades. Depression, substance abuse, suicidal ideation, and suicide have become a fundamental issue to address in medical residency. Also, burnt out and mistreatment in the training and learning environment. In 2019, the New England Journal of Medicine published this US national survey of all its surgical residents, where 32% reported gender discrimination. 32% also reported verbal and physical abuse, 10% sexual harassment, and 38% burned out symptoms, which were more common among residents who reported mistreatment. Also, mistreatment was associated with suicidal thoughts. Physician burnout is the epidemic of our profession, not of our time only. We know it has been with us for a very long time. Research has provided the evidence regarding the personal and professional repercussions of physicians' burnout. Not only does it impact patient care and safety, but also our own well-being and mental health. We are facing both a crisis and an opportunity. We need to address the drivers of burnout in physicians, such as workload, demands, lack of control, and work-life integration. But also we need to reinforce the key drivers to engagement that lead to find a meaning in work, and that could lead to prevent or recover from burnout. The question is, how can we change? Medical education new paradigm in the 21st century is competence-based education. Self-care and well-being have to be acknowledged as a professional competence for physicians and all healthcare workers. And yet again, this is not a new issue, but perhaps it will be catalyzed in the context of the COVID-19 pandemic. Just a few months ago, the US National Academy of Medicine published the report Taking Action Against Clinician Burnout, a systems approach to professional well-being, not only for documenting the causes and consequences of burnout, but also to share a systems model of clinician burnout and professional well-being, in which organizational and environment factors are predominant, but also the individual mediating factors. The consequence, however, leave no one unaffected. Therefore, learning and improvement must occur. How can we impact the individual factors from a medical education point of view? Can you teach and learn self-care and well-being? The answer is yes. And as a scientist, we need to find the evidence to support it. Professional competences and professional identity formation are both paramount to medical education and learners. Their development should be included in competency-based curriculum design, not only in the formal, but also in the informal and hidden elements of the learning environment. And this is the real challenge and a great responsibility. An unprecedented institutional social responsibility that includes to address the issue not only of mental health, but of well-being, and not only with a crisis management focus, but with formal institutional programs. With a systems-based intervention that not only prevents burnout, but mainly promotes the development of the personal professional competences of self-care and well-being, and reinforces the environment factors that promote well-being. Well-being programs for medical students are being designed, implemented, and documented around the world. The Vanderbilt School of Medicine program in Nashville is a pioneer and has been successful by articulating the previous existing university support services and resources in a program especially delivered by mentors to medical students, strongly focusing in a model of learning communities and peer support. In Mexico, in our school, we have a well-being program for medical residents and fellows that focus on both the academic and personal well-being and the professional development of the resident. The program includes the articulation of curricular design and strategies, mentoring, group and peer strategies such as battling groups, and support services such as counseling, mental health services, and substance abuse prevention. Again, the pandemic brought a new challenge and opportunity. Since April 2020, our program has been implemented fully in virtual electronic platforms. You are seeing in this slide the actual digital flyers that we use to promote the services and activities of the program with residents and fellows. The pandemic has brought us apart physically, but closer as an interconnected community. In conclusion, a professional and human network could be the basis to influence the residents' academic and personal well-being, as well as his, hers, theirs professional development. Residents' well-being is human well-being and dignity. Mental health is human health. We shall do everything in our hands and minds to flourish and to protect it. I am thankful for your time. I wish you well-being, I wish you health, and I wish you serenity in these critical times. Thank you very much.
Thank you, Dr. Diaz, for sharing with us that excellent mental well-being program that you already have in existence at your institution that undoubtedly probably created a level of resilience for your residents and students and healthcare workers. I'm sure there'll be also lots of questions for you later on. Let's move on to Dr. Jennifer Russell, who will also be Dr. Hervita Dietry, who will also be sharing the mental health program at her workplace. Dr. Dietry is a psychiatrist and lecturer at the University of Indonesia and the Cipto Mangunkusumo National Referral Center in Jakarta. She's a board-certified psychiatrist and a consultant psychiatrist, subspecializing in community psychiatry. So, Dr. Dietry.
Thank you very much for your introduction, Dean Adiba. And once again, I also want to raise my thankful to the Dean Ari and the distinguished panelists, all of you. It is a great honor to given this opportunity to give presentation on behalf of my university and also my hospital, Cipto Mangunkusumo Hospital. In my today's presentations, I will provide you an overview of the ongoing COVID-19 pandemic in Indonesia, the challenges that we have faced as a healthcare workers for the past 5 months, and the many ways we have tried to understand and also help our healthcare workers in our surrounding in my hospital. So here's the overview of global COVID-19 cases, but today I will specifically focus on and talk about Indonesia. Currently, Indonesia ranks 23rd in the world and second in Southeast Asia after the Philippines. In Indonesia, the number of deaths among confirmed cases has been reported higher compared to the average global death rate, even though we also have a recovery rate higher compared to other countries. However, we realize that the number of confirmed cases may continue to increase, or it may not even reflect the actual situations that we face recently, because there is still a lack of availability of screening tools. Thus, the proportion of populations that has been tested is also relatively low. The positivity rate, especially in Jakarta, the capital city of Indonesia, from where I'm presenting right now, and even in Indonesia as a whole, is higher than the threshold determined by the WHO. This reflects that enormous challenges and the need for services faced by the healthcare workers in Indonesia is still quite high. If we combine all of the information from various current headlines in Indonesia, we can conclude that healthcare workers in Indonesia face quite a lot of challenges related to morbidity and mortality, challenges in the workplace, and challenges as an individual belonging to a community. Seems like the previous panelist said. Morbidity and mortality data, especially in some type of healthcare workers, which is confirmed with the COVID-19, is not centralized yet. But I want to share in front of you the mortality data that has just been published by our Professionals Medical Association in Indonesia, show a relatively high death rate compared to other countries. Viewing these issues from the perspective of needs and burdens on the population, the loss of one doctor translates to more than 121,000 citizens becoming unable to receive healthcare services. So that's why I'm very happy to be invited in this meeting, in this sessions, because talking about mental health and also health system for the healthcare worker is very important. If data is projected to the needs of specialized healthcare workers, I assume the number will be greater. If we are talking now related to the healthcare facilities, the challenges faced by the healthcare workers is founded on the lack of specific knowledge and skills, including the use of PPE, how the way to use a PPE according to the standard, which is ultimately affects their compliance to the standard for PPE use. But now in Indonesia, the number of cases that require care and the continuous possibility of transmission further necessitates the use of PPE, while limited resources and capability to restock still have not been completely restored. The number of staff exposed increases the gap between the healthcare worker-patients ratio. Therefore, why the healthcare workers in Indonesia are burdened with a high workload and burnout, especially because providing healthcare service have becoming increasingly uncomfortable, as we know that they might experience dehydration or hunger associated with PPE use for extended in a period of time. The limited screening process, long wait time for testing results, and limited access to the information regarding test results once again increases the risk of exposure to the healthcare workers from patients, caregivers, peers, and partners. Related to the role of healthcare workers as part of the society, we have become a possible source of transmissions to our family and also the community. Consequently, this often leads to discrimination and stigma towards us as a healthcare workers. Furthermore, healthcare workers are potentially exposed to the infection when we use public transportations or spend time with our families around in the community. Becoming a source of infections will be duplicate the stigma, because we such kind of a source of infection towards patients and other personnel in our hospital as well. Another source of negative perceptions toward healthcare workers is related to the commercializations of health issues, beginning with the cost of screening until the notion of falsely claiming that patients are positive to get more incentive and financial aids from the government. So I work in University of Indonesia, Universitas Indonesia, in collaboration with the biggest tertiary hospital, academic tertiary hospital, Cipto Mangunkusumo Hospital. We have more than 900 beds with around 70 until 100 beds for COVID patients, including the intensive care unit. We have more than 7,000 workers, health workers, including the registrars. So from all these challenges, along with the efforts to provide services that that fulfills the standards of quality care according to the hospital emergency preparedness plan. My Department of Psychiatry, strive to and involve in the development of various mental health programs as our also social responsibility for the community who are affected with this pandemic. Including, we try to integrate mental health into general health services. I will present all of the programs into 4 sessions. So first is about mental health need assessment. This is as kind of an online survey. Was invited more than 390 personnel in our hospital. Approximately 40% of them were experiencing anxiety and depressions. The primary cause of their anxiety was concern regarding to their physical health status. So again, physical health and mental health is become a very integrated as one part of the human, especially because they think that the workplace is unable to protect them. Another cause of their anxiety is the fear of transmitting this infection to their family member, as well as worries related to the cost of living and treatment fees, and the stigma they might have to face if they become infected in our hospital. Based on these needs, our hospital, together with the government, provided incentive, safe transportation alternatives, and living space for healthcare workers that are working in special COVID-19 service units. Other than anxiety and depression symptoms, based on our SRQ test, there were health workers also have exhibit symptoms of PTSD, psychotic symptoms, and even suicidal ideas. Based on that existing condition, several requirements were identified, including the need for clear and accurate information regarding this disease and its treatment, and examination pathway and its implementation, adequate provision of PPE, as well as additional livelihood incentives such as provisions of living space and financial support. Other needs that were iterated include the opportunity to share their opinions with leaders, peers, healthcare, and mental health care workers if needed. Different from the clear need to maintain their physical fitness, the need for mental health services is still ambivalent, like what previous panelists also mentioned in Malaysia, including from those exhibiting symptoms, but they still try to respond our counseling practices, but in the other hand, they feel very ambivalent related to how they can cope with that counseling practices. So I will discuss more about the counseling practices in the next slide. So with the demand for information to overcome the current situation and condition, our department has also prepared educational materials. This was developed by psychiatric residents in their community psychiatric placement and psychoeducation module. So this is try to help to improve the understanding about mental well-being, stress, and anxiety management. All of these educational materials are accessible through YouTube and other social media platforms. So not just only for the health workers, but also can see by all the communities. The challenges lies in this educational material is related to evaluating the impact of these materials. And about telecounseling program, we use also the online counseling program. Our department provides counseling services for those who require it. So this is as kind of a self-register. This includes individual counseling, groups, and even peer counseling, focusly for the residents. Most of our clients are actually from the non-COVID-19 service units. The need seems to be great at the beginning of the pandemic, but it continues to decrease with time. Most of the anxiety cases present with somatic and manifestation and sleep disturbance. This is affected 1 from 3 healthcare workers who are admitted to our counseling program. It is mostly related to accuracy, the available information, durations of the pandemic, and screening test results. Although many have registered themselves for these services, not few end up canceling or rescheduling their appointments. Therefore, it seems that the need for treatment is not followed by the appropriate help-seeking behavior. Challenges are needed related with the time for consultation that often overlaps with working hours or the need to rest. Another challenge is that for these services is confidentiality and possible stigma, both from themselves and from the environment. Mental health care programs, once again, cannot be separated from general healthcare programs, as previous expressions have shown that the concern is regarding the need for general healthcare. Therefore, the integrations of mental health services into the programs developed during the COVID-19 is very essential. Healthcare workers who at risk of exposure, as well as those who are infected, should be given support to easily attain screening services. Using the facility for quarantine, so we have a Wisma Sahabat or House of Friendship for them who need a quarantine or isolation, if it is not possible to do so in our home. So if healthcare workers experience more severe symptoms, just like any other patients and services, healthcare workers shall receive the opportunity for their cases to be discussed in a multidisciplinary consultative team, which is done through an online platform to decrease the risk of transmissions. And patients, also the family can apply for our program, Friendly Corner, if they're needed. So from this program, they can access electronic communication services to the patient, because we cannot receive accompanying person in our inpatient treatment, and then mental health counseling if they require it. Last but not least, healthcare workers are monitored by our hospital for 3 months post-discharge to ensure the physical and mental health status, to ensure that the isolation protocol is still followed until they are allowed to come back to the work. So this will be such kind of our wrap message, that based on the existing condition and the experience from building our services, continuous development is still needed to ensure that our services are really developed based on the data, especially to ensure accessibility and affordability. We believe that the integration of health and mental health services for healthcare workers during a pandemic process to fulfill the existing requirement. Integration also need to be developed for the communication of evidence-based information. I'm still keeping in mind that the end of this COVID-19 pandemic is still uncertain, and adequate internal support system at work and in the community needs to be developed, beginning from peer support until the provisions of professional services. So thank you very much for the models that given in Malaysia. So we also can try to develop the same in our institution. This is, we really hope that can also reduce the stigma that arises from the pandemic. So thank you very much for your attention, and special thanks for all of the FMOE colleagues. Thank you very much, Dean Adiba.
Thank you, Dr. Dietry, for that comprehensive overview.
Professor Adiba, you're muted.
Yes.
Okay. Now, okay, thank you very much, Dr. Dietry, for sharing that comprehensive program that you have at Universitas Indonesia and Hospital Cipto. We'll move on to Dr. Jennifer Russell, who's a clinical psychologist at the McGill University Health Center in Montreal. She's also the Director of Clinical Training for the Department of Psychology and Clinical Coordinator of the Anxiety Disorders Program. So Dr. Russell.
Thank you very much. It's a pleasure to be here. I'm just trying to get my screen share going. There we go. So I'm going to be speaking today a little more generally about what we know so far about mental health of frontline healthcare workers in the context of COVID-19. And I'm going to share a little bit about what we've been doing here in Montreal at the MUHC. And I wanted to start with this quote, which I found very powerful. That this event, the COVID-19 pandemic really has undermined the sense of safety of our societies, where progress is often considered relentless, life increasingly better and longer. We, up until quite recently, thought of epidemics like this as really a waning memory of past centuries. And so the COVID-19 pandemic has promoted this mounting awareness of our intrinsic vulnerability amongst the sort of broader community, but I think particularly among our frontline healthcare workers. And so I wanted to speak today kind of globally about, what we know about the psychological aspects for healthcare workers during COVID-19 in terms of level of distress, and also in terms of some of the things that seem to be contributing to this distress. And then second, I'm going to talk a little bit about mental health interventions for COVID-19, sort of really briefly talk about what we've done at the MUHC, and what seems to be the sort of recommended approach to take. And so, as some of the panelists, other panelists have already mentioned, we know that psychological distress appears to be increasing among healthcare workers in the context of COVID-19. So across the board, we're seeing higher levels of depression, more anxiety symptoms, subjective stress, difficulty with sleep, problems with insomnia. And this seems to be increased, particularly among female staff and among staff that have more direct patient contact, and particularly staff that are having more direct contact with COVID-19 patients. And there are a number of concerns that seem to be associated with this, which have also been summarized already. So fears about infected family members, worries about the safety of our colleagues, feelings of exhaustion and fatigue. There's some evidence that nurses may be more anxious and depressed than physicians. And some of this seems to have to do with the level and the intensity of the direct patient care and the patient contact that the nurses in particular are having. We also know that there seem to be some kind of positive factors that guard somewhat against this and appear to strengthen morale amongst healthcare workers. And so some of this comes from a study from India, qualitative data from Spurthy et al., where they found that factors like having supportive and proud family members and colleagues, positive role models at work, feeling validated and appreciated by peers, by patients, by community members, positive caretaking experiences, a sense of being validated, having sufficient knowledge in terms of ongoing healthcare tasks, but also in terms of the infection itself and the use of protective equipment. And finally, to some degree, an acceptance of the possible inevitability of infection, particularly for staff working in some areas, seems to protect somewhat against the mental health impact. One of the things that seems to really impact the level of distress experienced by healthcare workers is this idea of moral injury. This is an idea that's derived from military settings. And it's the notion that when a person finds themselves in a situation where they feel overwhelmed, where they perhaps feel unprepared, and they find that they're being asked to engage in an action or to not engage in an action that challenges an ethical or moral code, this leads to what's known as moral injury. And so this could happen, for example, when a person does something themselves that they feel is against their moral code, and they feel guilt or shame, or when they observe someone else doing something that feels like it's against their ethics. And in that case, the person may feel a sense of contempt or anger, helplessness, lack of trust. And we know that these factors can lead to psychological distress, and certainly this is something that we've been observing in our healthcare workers, and that the literature is starting to speak about as being part of the mental health impact of the COVID-19 and infection. And so I'll give you a few examples from some of the healthcare workers you know, for example, making families or asking families to say goodbye to their loved ones from outside the room, you know, watching families go through the sort of isolation that's required by the infection, being told that they have to accept that people will die, even if it could have been avoided, because we're at war against the virus. So we had an incident, for example, that happened in our emergency department where a patient passed away because due to the COVID precautions, they couldn't deliver CPR until the patient was intubated. And it was very, very hard on the staff. And it's one of the things that, you know, that was brought to one of the support groups that we had going in the ED. And there are some important risk factors for moral injury. So healthcare workers that feel there's a lack of support from hospital leadership, from their family, friends, from society, feeling that they're unprepared psychologically for the struggle against COVID or for the work that they're doing, being exposed to the deaths of very vulnerable people or exposed to additional types of trauma, for example, in the ICU. So, for example, you know, another quote from a healthcare worker mentioning that they sort of worry about their own health, about their family, not knowing if I would be protected properly. So understanding that policies change, but that the PPE precautions made staff, especially in the initial phases, very nervous. Healthcare workers had concerns about how well they were being protected, sometimes feeling unsure if they were. And so this is an example of this sort of perceived lack of support at an organizational level. And then there are also a number of protective factors in terms of moral injury in healthcare workers. So at the organizational level, having a culture of self-care and coping strategies. And I think from some of the other panelists, we've heard examples of these types of well-being programs, for example, that really support the mental health and the mental resiliency of our frontline workers. Having good quality information, accurate and timely information. And then also organizational strategies we can use, like partnering together less experienced with more experienced workers, thinking about rotating staff between very high stress roles and low stress roles, offering peer support programs, spiritual or religious guidance or direct mental health support. At the team level, team cohesion and high morale tend to be, of course, more protective in terms of moral injury, having a sense of shared purpose and strong leadership. And then at the level of the individual, feeling that a person is sort of educated about moral stressors and injuries, that they're educated about stress reduction activities, that they practice acceptance, self-compassion, and use what the first panelist was speaking about in terms of psychological first aid, all of these strategies around self-care, rest, exercise, time out, basic stress management strategies. So, you know, here is another quote, a healthcare worker saying that although the COVID-19 work is very difficult, the people themselves can make it positive. So we kept going, we gave everything we could, and without each other, I wouldn't have managed to keep coming into work. In terms of mental health care strategies, there's a model. So when we were developing our programs for intervening in mental health with our staff, one of the things that we thought about was this PIES model. And the PIES model is the idea of thinking about these four factors: proximity, immediacy, expectancy, and simplicity. So trying to keep staff close to the front line, keep frontline healthcare workers close to the front line, even if they are having sort of mild symptoms that aren't interfering with functioning, even if we have them on altered duties, making sure that interventions are offered as quickly as possible. So getting help before the initial distress escalates into a crisis. Using a strengths-based, very positive focus, try to demedicalize very normal responses in difficult times. And then simplicity, trying to keep our interventions simple as often as possible. At the MUHC, we developed a few different types of interventions. So we had a telephone hotline where we offered, the telephone phone-in support, It was a listening line. It was also used for referral to other services if we thought that that was appropriate. We held in the early stages groups, sort of peer support and psychological first aid groups for emergency department staff and also for ICU staff. We developed a program that focused on more individualized assessment and brief intervention for frontline and for really all staff members, where we did a needs assessment, offered a brief intervention of up to perhaps 6 to 8 weeks. And then if we felt that someone needed something more, we referred them on. And workers could refer themselves to this, or they could be referred from the hotline or the groups or from other places in the hospital. And what we found is that we had really the most solicitation of this in the very initial phase of our treatment of COVID patients at the MUHC. So right away in sort of the very acute phase, people were using the hotline, people were asking for help. And most of them actually required relatively short-term intervention and support. So for the most part, it was a matter of I think, kind of trying to provide basic first aid and reassuring and validating people's distress. And I should note that at the MUHC, we're in a fairly nice position now where we became a COVID treatment center around the beginning of April. And as you can see from the graph here, our treatment of COVID cases has dropped off nicely. And so at least in terms of the first wave of infection, we're very far down from where we were a few months ago. In a general sense, I think it's clear that the step care principles are very useful in a pandemic, and I'll go through this quite quickly, but because I know we're pressed for time. One of the things that's come out for us at least, and I know this might sound a little controversial, is that although we are very concerned about the mental health care of first-line healthcare workers or frontline, we're trying to avoid the tendency to catastrophize about this kind of upcoming wave of mental health difficulties. That what we're seeing, or what we tend to be seeing, at least at our site, is more of like an acute stress response. And just like in PTSD, those acute stress symptoms don't always develop into longer term problems. And so it is quite possible that many people and many of our healthcare workers will ultimately cope quite fine and not necessarily require special interventions. And so we've been working to try and convey this expectation that people will get through this and that it is valid and understandable for people to be experiencing some of the symptoms that they are, particularly in the moment. In terms of self-care, the sort of stepped care principle idea is to start, with the level 1, trying to offer people self-directed help. This is especially useful when people have mild symptoms and no significant dysfunction. At level 2, for people who have more intense reactions and some dysfunction, to think about brief supportive interventions. So things like problem solving, perspective taking, some of the basic cognitive strategies, or psychological first aid. And then at the 3rd level, focusing on more specialized psychotherapeutic interventions. And so this would be more for, in the case that some healthcare workers, and we can expect that this may happen, may ultimately experience more severe, more chronic anxiety, depression, PTSD symptoms, or suicidality. And especially when that occurs with dysfunction or risk, offering things like trauma-focused CBT or therapy for complex grief reactions. So to sum up then, the COVID-19 pandemic, of course, it's really profoundly altered every aspect of life for everyone, but particularly increasing vulnerability to emotional stress and to mental illness. Most of our healthcare workers appear to adjust relatively well, despite this strong acute stress reaction. But we need to keep in mind that they are, of course, susceptible to moral injury, which can predispose them to distress, and that organizational and team factors can be very powerful protectors against this, and powerful protectors against the subsequent mental health problems that I think we're all worried about. I will thank you very much for your attention. And once again, it was a true pleasure to be involved in this panel. Thank you for having me.
Thank you very much, Jennifer. That was great presentation. Let me try and summarize all the wonderful presentations that we've had from our panelists. We have gone over time, but I'm sure all of you would agree that it was time well spent. So in the next 10 10 minutes or so, I'll just quickly summarize and then direct some questions to the panelists, and also relay some of the questions that we have received from our attendees. We have a few questions directed to our panelists. I think from all our panelists, we've heard how the COVID-19 pandemic has impacted healthcare workers in all of our institutions. Some professions more so than the others. You've heard just in Jennifer's presentation, and also Dr. Diatry, that nurses seems to have more risk compared to doctors. And the importance of organizational and team factors in protecting our healthcare workers from moral injury and subsequent psychological distress. We've heard some wonderful programs from our panelists even before the pandemic. Dr. Diaz shared the mental health wellbeing program that they have in Mexico City for students and residents, that hopefully will instill resilience and provide some protective factors. And during the pandemic, Hatim shared the program that we have here in Malaysia, as well as Dr. Diatry and Jennifer, the comprehensive program that you have in each of your institution. So I think no doubt all of these initiatives that have been taken by all of our institutions, and no doubt I think many institutions around the world, may have somewhat mitigated and otherwise you know, a much worse scenario in terms of development of mental health, negative consequences and well-being amongst our colleagues. I have some questions directed to both Dr. Diaz and Dr. Russell. Either one of you can take this question. I think you both stressed the importance of self-care, and I think this has been something that we are hearing more and more, that needs to be incorporated into both the undergraduate programs as well as residency training programs. Are there examples of, you know, of programs that that you've incorporated into actually the undergraduate curriculum or the resident curriculum, that you have evaluated its effectiveness? Because it's something that, to me anyway, it's quite new.
Thank you, Dean Adiba, and everyone for this wonderful panel and presentations. Yes, the competency-based education is gaining more and more space in the academic medicine scenario, and actually we are already working in the undergraduate level with the competency-based curriculum, which actually has not only the strategies to develop the curricular competence of professionalism, which has also the self-care and well-being competence inside, integrated to professionalism, but also this the evaluation and assessment methods that we will have results in a couple of years. When the first generation of our class of these students in this curricular design finish the medical school. In respect to residents, to medical residents, we have currently one research protocol actually related to the possible correlation of changes in the in the residents' well-being and burnt out related to participation in the well-being program, which is being held in academic protected times. So it's curricular, but it's still not in our curriculum design. So we are going to do that the next step. And I'm sure Dr. Russell can share the experience in Canada, and I know that they and in the United States, they have this competency base already.
Yeah, so we also do, thank you. We also do follow a competency-based model that does do a nice job of encapsulating self-care and well-being. And we're not collecting data on it, although it's making me think that perhaps we should be, so that we can study those outcomes. But one of the things that I noticed at the beginning of the COVID-19 pandemic here in Montreal, when we first opened up our hotlines and our peer groups, our residents, our psychology interns, the students were actually some of the stronger solicitors of the services, not necessarily because they were struggling more, but because that culture of self-care is, I think, more a part of the training curriculum now than it has been in the past. And because I think there's a generational destigmatization of mental health distress and the pursuit of mental health treatment. And so I think that's a really positive direction. We do have other well-being programs for staff. Some of them were pre-existing. And so, you know, at the institutional level, we have yoga once a week. We have someone who comes in and offers yoga free for students and staff members. We have sometimes people come in and do chair massages. We'll have like workshops for staff on sleep. We're lucky to be in a building that's on the side of a park, and we sometimes will take, you know, walks up the mountain, either organized at the institutional level or within a department. But collecting data on this, I think, is an excellent idea. And I think all of the training and curriculum and culture is moving this direction. And I hope that COVID prompts us to keep that up and enhance that.
Thank you.
Thank you.
I'm going to take the opportunity to relate some of the questions that we have from our participants. There are some excellent questions here. And to you first, Jennifer, a question from Budi Santoso. What's the best treatment from your experience and evidence to treat moral injury? And do you have tools to score severity of moral injury to predict successful treatment? An excellent question from Indonesia.
That's an excellent question. Thank you. I believe there are tools to score moral injury. I'm not acutely familiar. This isn't actually an area of expertise for me specifically. It's something that I've learned about over the process of the COVID-19 pandemic, and in the process of intervening with healthcare workers and trying to understand better what the you know, what the kind of central focus and risk factors and protective factors might be. In my experience so far, I find that for the moral injuries themselves, there's sort of two approaches that I use that are probably most evidence-based in this area. One would be the sort of cognitive behavioral techniques focused on cognitive restructuring, helping people to, you know, sort of understand this sort of the beliefs kind of underpinning their concerns about their own behavior, about the behavior of others, and helping people to kind of shift their perspective and come up with sort of a different model of how to think about a situation. So if you think about a situation where you feel that you haven't offered adequate care to someone, but really the limit to offering that adequate care had to do with the need to follow COVID-19 precautions, then there's a much kinder way, a much more compassionate way that you can think about that to yourself. I think the principles from acceptance and commitment therapy are very useful as well, based on, you know, Russ Harris, for example. I don't know if people are familiar with it, but he put out a really great sort of reader on I think it's called Face COVID, with principles from acceptance commitment therapy about the importance of kind of accepting reality as it is, using mindfulness-based strategies, and then connecting with your values and kind of committing to to sort of moving forward in a way that's consistent with the things that you feel good about and that bring meaning to your life, rather than to focus on what's difficult. So that's this is how we've been managing it, and I find that combination of techniques has been most effective.
Thank you. That's excellent. A question for you, Hatim. One of the main barriers to PFA administration was stigma surrounding seeking help from the mental health team. What more can be done to reduce the stigma and improve communication with mental health professionals? I think many of you also touched on the problem of stigma with COVID and mental health. So, Hatim.
Thank you very much for the question. I think stigma is a huge problem. We see a lot of the healthcare workers refuse sometimes to come to get help just because being worried of being stigmatized. I think the most important factor is to educate people, to give the correct information and to give the correct message. We must tell that it's normal to have distress under a certain situation, and seeing healthcare workers doesn't make you a second degree citizen, or being a weak person or weak personality. And I think the support from the higher management and the government is also very important, and also issue of confidentiality, that I think we have to protect the information. If anybody comes to seek help, that must be protected as well. I think basically education, correct message, and information.
Great, thank you. This is a question I think will be relevant to all the panelists, except for maybe you, Jennifer. It's about the rural urban divide. So health and mental illness happen in both rural and suburban areas. For those who have access to health centers, they can get consultation. But how about those who do not have any access to health centers? Dr. Dietry or even Hatim?
Okay, maybe I will start, Dean Adiba, to share about our experience in Indonesia. So yes, this is still quite challenging to us if we are talking about accessibility. So we try to conduct such kind of a self-assessment, online self-assessment. So we try to distribute it in our services, in our mental health services, psychiatric center. But once again, the problem is related with the access for that online. So another possibility is that we still struggling to advocate to our government is trying to integrate mental health into health services. So we really want to the government, especially the health workers, to use simple questionnaires, mental health questionnaires related to the anxiety and depression mostly. So they can give to the patients directly while they are treated physically. So they also can try to fill the questionnaires while they are waiting in the waiting room before meeting the doctors. So that's the simple examples that we ever had. But we are still trying to advocate the government to give more accessible access, especially online, from rural and urban. Thank you.
Thank you. Hatim, do you have any examples from?
Yeah, I think the online method is good, but I think another additional thing that we can use is by training the GP, the primary care physicians, the GPs, and doing what we call community psychiatry service. In our department, during this COVID session, we do a lot of webinars for GPs on training them how to assess or even handle mental health issues, especially those who cannot afford to come to the urban areas. So empowerment of the primary care doctors is also one of the ways.
Yeah, that's an excellent point. A question on this directly directed to you, Dr. Directory, specifically if the online service provided by CIPTO is also available to all Indonesian doctors in other areas.
Thank you very much for the question. So actually, yes, in our need assessment, we get that point that the services also needed by others professionals outside from my hospital. But recently, our hospital is still developed that for our health workers. But in the same time, I know exactly that our association, Psychiatric Association, Indonesian Psychiatric Association, also develop the same services for all of the people, and not just only for the health workers, but also for the community in Indonesia. But unfortunately, I guess I will learn to evaluate that program and then try to expand the program and also improve the program. And the other message that I also think that this is not just only about getting a professional's help or services, but trying to empowering person, trying to give a lot of time for empowering person, health workers, and also the community to trying to look after themselves. So self-care and well-being will be distributed to others too, not just only contact teleconsultations.
Thank you. Given that we're running out of time, what I'm going to do is to utilize this question to ask each of our panelists what has been the biggest challenge in implementing mental health programs for healthcare workers during the current pandemic. Perhaps I'll start with you, Dr. Diaz. What has been your biggest challenge?
Our biggest challenge has been finding the time, the protected time for example, for medical residents to have the sessions, to have the opportunity to have to attend the sessions, and also to try to understand the needs that they have and offer different strategies that are more likely for them to attend, because you need the resident buy-in. You know, they need to feel that it's going to help in their own well-being and self-care. So this and also the transformation of everything from to a virtual platform. So that will summarize the big challenge, and not to become a burden to the resident, because you know, it cannot be another thing or task to do. It has to be something appealing and that it's well received, because if not, you can contribute to even more burnout.
Thank you, Dr. Russell.
I think that it's twofold. One really significant challenge has been the challenge of keeping our existing mental health clinics up and running and ensuring adequate care for our patient population, while pivoting and learning to offer services in a different way due to the COVID-19 precautions. And also find the time to develop and implement programs for our healthcare worker staff. And then the second major challenge has been probably in the area of the stigma of mental health and self-care among healthcare workers, you know, convincing healthcare workers that it's okay. You know, we had to take our groups to the emergency department and like put a section where people could just come and participate in a group in the emergency department itself, because otherwise people wouldn't seek it out. And so convincing healthcare workers to ask for help when they need it and to ask for it early and not to wait, that's been challenging. Thank you.
Thank you. Hatim?
Yeah, I think the biggest challenge for us is probably the stigma associated with mental illness, and to promote the service to the healthcare workers. I think the second challenge is to adapt to the new norm of this social distancing, no more face-to-face service, and so on. And the third challenge, I think, is the chronicity and the uncertainties of this ongoing pandemic itself. I think makes a lot of us, even the providers, becomes distressed.
Thank you. And Dr. Gayatri.
Thank you, Prof. Adiba. My own self-learning from this session is how we can try to find a method, which is a method can touch to everybody, not just only healthcare workers, especially for the healthcare workers, but by support the empowerment and appreciating the resilience and coping system who have been developed. So this is not just only about mental health, but using values, norm, and then everything that happen in the human as part of as a heart of the treatment. So I guess that's the most important, who can engage people come because they feel appreciated for all of the potentials that they have. Thank you.
Thank you. We still have a few questions from our participants, but unfortunately we have run out of time. We will try and answer those questions online rather than through this webinar as best as we can. And feel free to send any additional questions to AAHCI, and we will do our best to answer those questions, and the email has just been provided in the chat group. I will now hand over the microphone to Dean Ari to make his closing remarks. And then finally, thank you to all the panelists, and especially to Dr. Russell and Dr. Diaz. It must be late where you are in Montreal and in Mexico, so good night. And to all our participants who have stayed with us this morning. So Dean Ari, over to you.
Yes, thank you. Thank you very much, Dean Adiba, for this important webinar. And also I think, and also thank you for all panelists and participants, active participants as well. And then I think we have just got the fruitful webinar, not only for us, but also for all participants. Thank you again, and see you maybe after pandemic next year, maybe somewhere. Thank you.
Thank you.
Thank you, Habiba.
Thank you, panelists. Thank you, everyone. Great job.
Thanks, everyone.
Thank you.
Thanks, Prof.
Bye.
Thank you. Thank you, Russell. Thank you, Hatim. Thank you, Dia.
Thank you. It was a pleasure to meet everyone. Thank you for organizing this.
Yes. Thank you very much. Thank you very much for the invitation. It was really nice meeting everyone, and congratulations on all the excellent programs that you share. Thank you.
Thank you. And I certainly learned a lot from all of you and the wonderful programs that each of you have in your own institutions. Lots to learn from each other. Thank you.
Thank you.